Welcome to From Global Travel to Local Triage, Practical Infectious Disease Preparedness for the World Cup 2026, which is starting this week, as we know. I'm really thrilled to be joined by our wonderful speakers today. I also looked at the audience and I see a wide variety of clinicians from different areas. And so it's really great to have that sort of audience. So we'll have not just ID docs, but I see some emergency medicine, critical care, and other groups, infection prevention. Okay, so this is our acknowledgement. We are supported by the Administration for Strategic Preparedness and Response, or ASPR within HHS. The disclosure here, showing that to you all. Hi, everyone. I'm Erica Shenoy. I'm your moderator today. I'm Chief of Infection Control at Mass General Brigham. I'm an ID doc at Mass General Brigham, as well as Medical Director of the Region 1 Emerging Special Pathogens Treatment Center, or the RESPTC at MGH. Delighted to have Dr. Casey Coffey here. She's the Medical Director of Infection Control at Mass General Hospital and Mass Eye and Ear. She's a physician in the Division of Infectious Diseases and faculty at Harvard Medical School. And Dr. Sarah Turbot, she is Medical Director for Antimicrobial Stewardship for Mass General Brigham. She's an Associate Laboratory Director for the Microbiology Labs at MGH and a physician at Mass General Brigham. So without further ado, we're going to go into our learning objectives. So we'll review the relevant EPI for travelers to the World Cup 2026. We're going to use a case-based format to formulate differential diagnoses, combining both EPI and presenting signs and symptoms, and focusing on the identify, isolate, inform framework, and then understand some of those diagnostic strategies and the importance of collaboration with our essential partners, both within your institution and outside of your institution. So I'll set the stage, which is that all the world from the ID perspective is a stage for infectious diseases. And one of the challenges that you all as clinicians will be facing is really separating signal from noise. The World Cup is going to bring together fans from across the country and the world in large gatherings, both at the games as well as all those events that are surrounding those games. Host cities such as Boston can expect to have an influx of fans from around the US and the world. I heard from public health leaders yesterday that they're expecting 2 million visitors to the Boston area over the course of the next several weeks. This raises, obviously, the potential for an increase in infections that are less common in our region on a background of endemic infections. Many of the syndromes that you'll encounter present with nonspecific features, making the epidemiology a key part of implementing what we call the identify, isolate, inform approach and establishing your differential diagnosis. So, of course, preparing for this, want to look at what has happened in the past related to infectious diseases and sporting events. And I just pulled out this one paper from the Vancouver Winter Olympics about 16 years ago. It occurred over a period of a couple weeks. And then following that, about a week later, 10 days later, 3 adults who had attended developed measles and were diagnosed with measles. There was a very large investigation, including whole genome sequencing, which ultimately determined that there were 2 separate importations of measles from Olympic visitors. This resulted in a total of 82 cases of measles during the time, and there were 2 outbreaks associated with this. Now, all the cases that were eventually identified outside the Vancouver area were linked to a single exportation. And that really goes to show how infectious measles is among susceptible hosts. So just keep that in mind. Now, we talk a lot about identify, isolate, inform. At its essence, it's identify individuals who are at risk of an infection that requires an action that you need to take. And you're going to use both travel and exposure plus their symptoms. You then isolate the patient to protect other patients and other healthcare personnel, and then you're going to inform. You may want to make sure that the team that's also caring for the patient knows that you are concerned about disease X. You're going to involve your local resources, which are generally infection control. And then often you're going to need to get additional history to assess if the patient is at risk for that infectious disease, including high consequence infectious diseases or HCIDs or other reportable diseases. And you're going to be engaging public health. Now, pattern recognition is really key to that identify step. And what we're doing here is just bucketing kind of syndromes that people might be presenting with. So think about fever and a rash, fever in a returning traveler, fever plus respiratory symptoms, and fever plus GI symptoms. And then you add onto that a layer of their history, exposures, epidemiology, and that'll really get you kind of in your don't miss category of infections that you want to make sure that you act on. I want to highlight this really nice algorithm that the CDC has developed, and this is really specific to special pathogens. Think of high consequence infectious diseases. Ebola's in the news, but also Lassa fever, Crimean Congo hemorrhagic fever, Middle East respiratory syndrome. These are all pathogens that are going to require additional actions from both infection prevention and from a public health point of view. It's a really great resource. It talks through what your state, tribal, local, or public health department will help you with in terms of testing. But what I really want to highlight here is another M pathogen, which is malaria and disease. So here it highlights the fact that malaria is the leading cause of travel-related hospitalization. So if you're thinking about a lot of travelers coming potentially from endemic countries, and on the right you can see the blue here are all the areas where there is malaria circulating. And lastly, on that part about malaria, we know that delayed diagnoses of travel-acquired malaria are very common, and they're associated with higher risk of severe malaria. Just last month, this study in pediatric populations was published. They found that most patients had visited West Africa to visit family and friends, and they were hospitalized when they returned in the subsequent months. And we're heading into not just World Cup, but school vacation. Fever was most commonly reported, 32% that were diagnosed with severe malaria, and delays to diagnosis happened in about a quarter of patients. Half of those with delays developed severe malaria. And those patients with delayed diagnosis have a 4.8-fold higher odds of severe disease. So there were a lot of missed opportunities, both on the pre-travel counseling, as well as if counseled, those who actually were prescribed and then took their prophylaxis. And all of our facilities really need to make sure that they can perform rapid malaria diagnostics to ensure appropriate clinical care. So here we go. You're going to put your thinking caps on, everyone actively engaged in this. There will be polls, as I mentioned, and I'm going to turn it over to Doctors Coffey and Turbot to lead us through the next several cases.
Great, thank you so much. And as we get started today, I think the real thing that I would like for folks to take home is to remember that this is an interesting situation where we have a mashup of travel-associated illnesses that we need to be on alert for, but we can't forget about all of the things that we would normally be screening for locally. Let's start with the first case. So, college reunion at the World Cup. A 35-year-old man from Heber City, Utah, presents to the emergency department with acute onset fever, new rash. He has come to the Boston area to attend the World Cup match to see Norway versus Iraq. And he's staying with a former college roommate, along with two other former suitemates who traveled from El Paso, Texas, and Baghdad, Iraq. The group has been together for about 2 weeks prior to symptom onset, spending time sightseeing in Boston. And what you'll see is that I've started to pull out some of the epidemiologic risk factors that may be key in your future decision making. So before you do anything else, the first question you want to ask is, do you want to isolate this patient? And we're going to go ahead and open this poll, and you're going to say, no, right now this is just a fever and a rash. I need to know more about this. Or yes, there's a number of concerning features here, and I would like to isolate first and get more information. So let's just see what folks would say. We'll give about 10 seconds. All right, closing out, it looks like the majority of folks would like to isolate this patient because there's a number of communicable diseases that can present as fever and a rash. Isolate first and get more information. So what's on your differential? I want you guys to be thinking what you're worried about and isolating and what those isolation precautions might mean. And I'm just going to pull in this word cloud of all the things that I know you're thinking about. Great, this is good. So you're thinking about measles. I think that was the #1 thing. But we also have to think about other fevers and rashes that can present. We didn't tell you anything about this rash so far. So it could be chickenpox, it could be shingles. Thinking about endemic infections local to our area, it could be Lyme. We can't forget about HIV because acute HIV can present as fever with a rash. So we don't want to anchor on one diagnosis just because this is a talk about infections associated with world travel. So what questions do you want to ask that might help differentiate these kind of generic fever with rash? Maybe you'd like to ask the rash characteristics, the morphology, the distribution, mucosal involvement, are the palms and soles involved? And then the temporal pattern. When did the fever start and when did the rash start? Because that can really help to narrow your diagnosis. And lastly, exposure risks. Do we know if this patient had any sick contacts, any recent travel? We described some of that in the prompt, any vector exposures, their vaccination status, and their immune status. So let's go get that information. What you want to think about is these buckets. The things that you don't want to miss, for example, would be measles. Measles is one of the most contagious infections on this planet to susceptible patient populations. So if you are thinking about measles, we need to think about isolating up front. The incubation period for measles is 7 to 14 days, which means roughly 7 to 14 days after exposure, a patient can start having symptoms. Remember the prodrome of the 3 C's: cough, coryza, and conjunctivitis. The rash itself is an erythematous maculopapular rash, and the rash appears 2 to 4 days after the fever onset. Remember that these patients can be infectious 4 days before to 4 days after the rash onset, and their risk factors are either being unvaccinated or undervaccinated, immunocompromised, or having a known exposure within the last 21 days. But we should also be thinking about varicella, another highly contagious infection to susceptible hosts. This incubation period is 10 to 21 days, with a prodrome of 1 to 2 days of low-grade fever and malaise prior to the rash. This rash is typically pruritic, vesicular, and appears in crops. So you'll have different stages of vesicles throughout the stage of the disease. Infectivity is 48 hours before rash until all vesicles have resolved, and many of the risk factors are the same as for measles. But as I mentioned, you don't want to forget some local or more common things that cause fever and a rash. So if we could just make that a little bit bigger. Oh, I think if you clicked it. We want to think about Mpox, we want to think about herpes viruses, we want to think about HIV. Then some of the more common viral exanthems in children, parvovirus, hand, foot, and mouth disease, and roseola. These should all be kind of circulating through your head as you're thinking about the patient when all you know so far is that they're coming in with fever and a rash. For those, you may want to think about whether they've had a new sexual contact, are they coming from an endemic setting, say for Mpox, and then also contact with children and children's secretions. So what this patient tells you is that his fever started 2 to 3 days ago. At first, he just had a cough, but assumed it was a virus, and now he noticed the rash today. The rash is on his face and neck and seems to be spreading down his body. He's not aware of any known contacts with measles cases, but he did attend a large family gathering prior to coming to Boston. Remember, he came from Utah. He states that he doubts he was vaccinated because as a child, his parents had religious exemptions to vaccines. His college friends do not have similar symptoms, although his friend from Baghdad noticed a new rash just starting today. And he says his friend from Texas is concerned because he takes a medicine for ulcerative colitis and thinks he could be more susceptible to infections. On exam, this patient is ill-appearing, febrile. He has a little bit of conjunctivitis and a runny nose. He doesn't have any oral lesions, but he does have an erythematous macular rash that starts at the hairline, and you see it going over his cheeks and behind the ears. So now you should be a little bit more concerned about certain etiologies. So typically in Massachusetts, we think about measles as being an imported infection. So most of any measles cases we have seen in Massachusetts have come from other places. The thing is whether we need to think about that domestically or globally. It's important to remember that we have seen increases in measles cases throughout the United States. And linked here is actually a map to the US measles tracker, which can give you some idea of where we are seeing measles cases in the last 2 weeks. And so that could be a helpful resource to you if you're wondering if this patient is coming from a place where we're having these pockets of measles outbreaks. And then if you look globally, you can see that measles has been an ongoing concern throughout the world to varying degrees of communicability. What this all relates to and the changes in the measles cases in the United States could be related back to vaccination rates. And so here I'm showing a map of MMR vaccine coverage for kindergartners by school year. And it should come as no surprise that as the coverage goes into the less than 90% category, those are some of the areas where we are starting to see increases in measles cases. So you can see that Utah is highlighted on both of the US maps, as well as certain pockets in Texas. But we can't forget about those other viral exanthems. On the left here is a map of varicella. This is an age standardized incidence rate for varicella. So varicella can cause two different diseases. One is acute, which is primary chickenpox, and then you also have shingles, which is a reactivation. And so adjusting for age, you can see that this is common throughout the world and may be related to the patient's age and their vaccination status. We also have to think about Mpox, which can present as a fever with a rash. We have that in the United States, but may also be travel related. And then all of the other viral exanthems. And so you can see in the map on the right, the entire world is lit up because you have things like human herpes viruses, which include EBV and CMV. You have parvovirus B19, which causes the classic slapped cheek rash. You have acute HIV, which we mentioned, and also hand, foot, and mouth disease. So discussing the type of the rash really is going to be the next clue to lead you toward a diagnosis. On clinical exam, measles has this classic brick red, blanching maculopapular eruption that starts on the face and spreads downwards, whereas varicella or chickenpox is raised, red, and itchy and can occur on all body surfaces. Mpox lesions typically develop at the same time and evolve together. So that could be one way to help distinguish Mpox from varicella. If you are thinking about isolation and precautions, it's important to think about which disease you're most concerned for because that will guide the precautions. So for measles, you would want to make sure that you have PPE that includes an N95 respirator. This should be fit tested to protect yourself, and the patient should be in a private room on airborne precautions. For varicella chickenpox, similarly, you would want to be wearing an N95 respirator, and the patient should be on airborne precautions. Whereas for Mpox, the current recommendations recommend an N95 respirator with a gown and gloves and eye protection. So what's your leading differential now? We had a fever that was followed by a rash, maculopapular starting on the face and spreading down. I think it's really important when going through the types of rashes to use the correct terminology because it really will also help inform your colleagues. So if we could click one more. On the right is a reference to describe the types of lesions that we mean. A macule is flat and non-palpable that can be red, brown, or white. And a papule is elevated and you can actually feel it with your hands. And this is different from a vesicle, which is fluid-filled, or a pustule, which is basically a vesicle that is filled with pus. So using these correct descriptors can lead you to the correct diagnosis. But let's say you're concerned about measles. How do you want to confirm that diagnosis? And remember, as you're thinking about this, to also inform your local infection control and the Department of Public Health.
Okay, so I will now be focusing on the diagnostic portion for this case. And I just want to take a step back. We've heard a lot about measles, primary varicella, and Mpox, and it's important to note that these are all locally and/or nationally reportable infections. And so for a lot of these reportable infections, the tests that are needed to diagnose them are really only available through public health laboratories and require public health approval for testing. And so if you have a clinical suspicion for one of these reportable infections, measles, for example, please use that informed step that also involves including your local infection control team, your laboratory, and the public health department, because that'll really ensure that the right people are involved and that the correct tests are being sent. So, next slide, please. For measles virus, the diagnostic test of choice is measles PCR. The preferred specimen type is going to be a nasopharyngeal swab. However, throat and urine swabs are also acceptable specimen types. Ideally, you want to collect these as soon as possible from rash onset because that's when they're the most sensitive. So ideally within 1 to 3 days of rash onset. However, they can be positive up to 10 days after rash onset. So if you see a patient on day 4 or 5 and you're concerned for measles, please still obtain the test and have it sent. Serologic testing is also available, although I will say it really should not be performed alone. IgM testing should be performed with PCR. And the rationale for that is that you can actually have negative IgM results within the first 3 days after rash onset, because again, it takes time for the body to develop those antibodies to measles. And then there also are reports of false positive results as well. So you really need to take the clinical situation, the epidemiologic risks, as well as both the PCR and the serology testing into consideration when you're making the diagnosis. IgM can persist for longer periods of time, and so for up to 6 to 8 weeks after acute infection. IgG antibodies do also exist and are commercially available. However, they do not play a role in the diagnosis of acute infection. They're really more to assess immunity response. So we are obviously concerned about measles in this case. And so it's important to think about post-exposure prophylaxis for measles because there is post-exposure prophylaxis available. And it is indicated for exposed individuals who are at risk for infection. And this includes people with a lack of documented immunity, meaning they don't have proof of a vaccine or a measles IgG antibody positivity, or persons who are moderately to severely immunocompromised, regardless of their measles vaccination or serostatus. So even if they've been vaccinated, because of their immune defects, they are still at risk for the development of measles infection. And there are different types of PEP. So one, of course, is MMR vaccine, and then there also is immune globulin. And the choice as to which one to give really depends on the patient's age, their immune status, their pregnancy status, and then the time since exposure. And so on the next slide is just an overview of post-exposure prophylaxis for measles, the choice and dosing guidance. This is the current Mass General Brigham guidance, and I will say it's been adapted from guidance from the Centers for Disease Control and Prevention, as well as newer guidance from the Canadian recommendations on measles post-exposure prophylaxis. And then we did also have some subject matter experts weigh in. What you can see here is that, again, it really depends on your risk, your immune status, and your time from exposure. The highest, risk individuals are, of course, infants, less than 6 months of age, and they're not immune due to age. They're not able to be vaccinated. Those children would get intramuscular immune globulin. Infants who are 6 through 11 months of age, if they're not immune, they can get MMR vaccine if there's no contraindication to that. People who are over a year old, who are not pregnant and who are not moderately to severely immunosuppressed, if they've not been vaccinated or have evidence of immunity, MMR vaccine is actually the PEP of choice if there's no contraindication. Pregnant women, however, if they're non-immune, cannot receive MMR vaccine. And so this is where intravenous immune globulin would be given. Same thing for our patients who are moderately to severely immunosuppressed. Again, even if they've had measles vaccination before, we still consider them susceptible. And so they would also get intravenous immune globulin. And so overall, how do you define moderate to severe immunosuppressed? I will say that's a complicated kind of definition. And so the Centers for Disease Control and Prevention does have guidance on this, as do the Canadian recommendations as well. So I would say, please look to those resources when you're trying to determine whether or not your patient meets those criteria.
Congratulations. You successfully diagnosed measles in this patient. But remember, the work is to identify, isolate, and inform. We're not done yet. We did either initially because of the fever and rash and some of the epidemiologic concerns, or after interview, I think everyone on this call would have put this patient into isolation. We managed the patient symptomatically, but remember his friends. We had a friend who was coming from Iraq who mentioned a rash on the back of the leg. While this doesn't necessarily sound consistent with measles, this person will still need to be isolated as they have been exposed, and further evaluation will be needed. We also have an asymptomatic friend who is on an immune suppressing regimen. So further assessment will be needed to know whether that immunocompromised friend will need to be quarantined and receive post-exposure prophylaxis. Let's do case 2. Another common scenario is a person who has traveled recently and is returning with a fever. So we have this 27-year-old woman from Massachusetts who presents with 3 days of fever, headache, myalgias, and fatigue. She returned 10 days ago from a 2-week visit to Ghana, where she stayed with extended family following completion of her postgraduate degree. While in Ghana, she spent most of her time in urban and peri-urban settings, but reports visiting relatives in a rural village with intermittent overnight stays in family homes. She recalls mosquito exposure and limited use of repellent. She also denies receiving malaria prophylaxis. After returning to the US, several family members traveled back with her, and they're all staying in Plymouth. Together, they have spent several days on Martha's Vineyard, hiking through the beach trails and the state forest. She has no localizing symptoms on initial review of systems, and physical exam is notable only for fever and mild tachycardia. She has no rash and no bleeding. Okay, so we now have fever in a returning traveler. Before you do anything else, do you want to isolate this patient? I'll give a few minutes for folks to answer in the poll. All right, so it seems like the majority of people are on high alert for fevers in returning travelers and concerned for potential contagious pathogens. Go ahead. So what is on your differential? Tell me what you're thinking. My word cloud will pick this up as you consider what could be causing fever in a returning traveler. Yes, excellent. So you're worried about malaria, but you're also thinking about yellow fever in the travel to an endemic area. Could she have Lassa fever? Possibly typhoid. But for more local concerns, could she have Lyme, Babesia, Anaplasma? Are we worried about Ebola in this patient? She mentioned a headache. Could this be meningitis, or is this just a fever not otherwise specified? Well, what do you want to know from her history that's going to make this more evident? You want to know where she traveled. She gave you some of that in the history. We know she's been to Ghana in rural and urban settings. We know that she has, and that she lives on the Cape and has been doing some outdoor activities. We also know when her symptoms started relative to travel. So she was in Ghana for 2 weeks, but she's been returned for almost 10 days now, and her symptoms started 3 days ago. So that's approximately a 7-day since return from travel that her symptoms onset. What are her potential vector exposures? We know that she was exposed to mosquitoes while traveling in Ghana, but she also has some concerns for tick-borne exposure in Massachusetts as she was hiking in the state forest and on the beach trails. And we know that she didn't take travel prophylaxis for malaria. So what is your differential? As an infectious disease specialist, I will say that fever in a returning traveler, we have to think about malaria if they were traveling to a malaria endemic zone, especially if we know that they weren't on prophylaxis. The incubation period for malaria is 7 to 14 days for Falciparum, Vivax, and Ovale, and up to 40 days for malariae. And those types of malaria are endemic to different parts of the world, which could be relevant in your investigation. Risk factors include lack of prophylaxis and exposure to mosquitoes and travel to an endemic area. One thing you would not want to miss, however, would be Lassa fever. As a viral hemorrhagic fever, the incubation period is 7 to 21 days, with risk factors being travel to an area experiencing outbreak. In this case, it would be relevant to know whether there was any ongoing Lassa activity in Ghana. And then any exposure to rodents or rodent excreta, which could include travel to more rural areas or places that have less barriers to exposures to rodents. Anytime you're thinking about fever in a returning traveler, you also want to consider typhoid. The incubation period for typhoid is 6 to 30 days. Risk factors include people who traveled without being vaccinated, those who are staying with friends or relatives, or visiting smaller cities or rural areas. Consider thinking about yellow fever. This incubation period is 3 to 6 days, and all you need is travel to an endemic area, exposure to mosquitoes. You would want to know if the person had been vaccinated prior to travel. But don't forget, we are in the Northeast. There's still a risk for Lyme, Babesia, Anaplasma, and they all have overlapping incubation periods, with Lyme being from 3 to 30 days. Babesia 1 to 4 weeks, anaplasma 5 to 14 days, and really the biggest risk is being in an endemic setting with a potential exposure to ticks. The epidemiology really plays a key role in forming the differential for this patient. We know that malaria is endemic in Ghana, so that is a consideration, but we also know that Lyme is endemic in the Northeast. This is a little bit of an old map, but from 2023, just showing the density of the Lyme infections in our area. Something else to think about is Babesia, which is on the differential and could also cause a similar fever with without localizing symptoms in this patient. We did bring up the question of Lassa. So in that region of the world, you would want to know if there were any recent outbreaks. So Ghana has some sporadic cases of Lassa, but it's not an area where we are concerned for ongoing outbreaks. But this can change, and so it's really good to know how to access this data quickly. We've included some links here for your reference where you can actually search, and this website is maintained by the University of Washington to give you some ideas of where active activity for these viral hemorrhagic fevers is ongoing. I think about fever in a returning traveler as doing a pre-travel visit in reverse, a structured approach to the returning traveler. So basically what you can do is use this CDC website, which this is CDC Travelers Health, enter the country that they've traveled to, and it kind of walk you through reviewing the itinerary, where they were going, when, and for how long. It'll advise you to assess exposures, because we give counseling on making sure you're eating safely, drinking safe water. Do you anticipate any contact with animals? And then we talked about insects, fresh water, including a sexual history can be important, as we mentioned in the earlier case. We also want to know which travel-specific vaccines they had and review their prophylaxis prior to travel, because these lack of these things is going to change your differential. And again, you can use CDC-specific travel guidance to build that differential.
Okay, I will briefly review how to diagnose malaria. So we do have a lot of tests available in the United States. Includes rapid malaria antigen testing, blood parasite smear, and then nucleic acid detection or PCR. So rapid malaria antigen testing can certainly be performed, and there is one FDA-cleared assay, the Binax Now malaria test. This looks for two proteins, a pan-malarial protein, which is aldolase, and then an HRP2 protein, which is specific to P. falciparum. This is done on whole blood, and the real benefit of this test is that the time to result is about 15 to 20 minutes. So it does give you a really rapid result that is also pretty easy to perform. Its sensitivity of all three methods is actually the lowest, but it still is quite sensitive. So if you look here for falciparum malaria, it's more than 99% sensitive at a parasitemia level of 0.02%. It is slightly less sensitive for Vivax at 81% at that same level of parasitemia. I will say for other malarial species, it has lower sensitivity, but for the most part, what we see in travelers that come into the United States is falciparum and Vivax malaria. The important caveats to note with this test, though, is that because of its reduced sensitivity, as well as the fact that it doesn't pick up all malarial species with the same degree of sensitivity, a negative result does not rule out malaria, particularly if your suspicion is moderate to high. It also does not provide any quantification of the parasites. And so, as you all know, you actually do need to understand what the degree of parasitemia is for malaria, as it does help us inform treatment. Moving all the way to the right with nucleic acid amplification or PCR-based testing, these often target the 18S ribosomal RNA subunits of these organisms. It's also performed on whole blood, and it actually is the most sensitive way to perform testing with very, very low detectable parasitemia levels. Time to result is dependent on how the test is ultimately going to be performed. There is one FDA-cleared assay, the BioFire Tropical Fever Panel. So if you have that on site and it's verified, then you'll get a result within 60 minutes. It's a relatively new assay, though, so I don't think a lot of institutions are using it. And so most would actually send this to a reference laboratory, which means that the result time would be on the order of days. It does provide some species level identification depending on the assay, but it also does not provide that quantification that is needed for treatment purposes. which then leaves our blood smears, which is still the gold standard for the diagnosis of malaria, where we're literally looking for the direct detection of parasites from the whole blood using both thin and thick smear. You can see here that they're not quite as sensitive as PCR, but they're still very sensitive. And again, if you have clinicians or laboratorians who are trained to perform this test, available 24/7, you can get a result within 2 to 4 hours. I will say, though, this is a test that does require expertise, and so it's important to know if your laboratory does have that availability, and if so, when. The caveats with the blood parasite smear is that it does allow for quantification, which is needed. And so, even if you perform a malaria antigen or a PCR test, you're still going to need a smear. But it does also provide some species level information. And so the big takeaway here is that if you're concerned for malaria, please reach out to your laboratory to find out what tests they use and order those so that we can make the diagnosis as quickly as possible. But we also talked about Babesia. And so it turns out that the diagnostic test for Babesia is also blood smear microscopy. And so on the right here is a thin smear of Babesia species. Some caveats to this, though, is that it can be difficult sometimes to differentiate Babesia from Plasmodium falciparum. There are a couple of pearls that can help with that. So Babesia will only show ring forms. They often have extracellular rings, as you can see here. They also form that Maltese cross, which I'm sure you all learned about in medical school, which is pathognomonic for Babesia. And then the rings are also a bit more pleomorphic compared to falciparum rings. So an experienced technologist should be able to make that differentiation, but I will also say the travel history is really helpful. And this is also where a rapid test like a Binax can be helpful, because if you have a high degree of parasitemia, but that Binax is negative, and they're in New England, then it probably is Babesia that you're dealing with. And so the diagnosis in this case is, drumroll please, Babesia. You can see the pathognomonic Maltese cross here. They did perform a quantification of the parasites, and there was about 1% parasitemia. The patient was started on therapy and did quite well.
Fantastic. So if we take away nothing else, remember that we are considering the overlap of the local and the traveler history, which brings us to our next case. You're getting very good at doing this now, so we're going to move a little bit more quickly. 32-year-old man presents to the Boston Emergency Department with 3 days of fever, cough, sore throat, and nasal congestion associated with mild shortness of breath. He recently traveled to Morocco. He's going to attend the Brazil versus Morocco match and arrived in Boston 7 days ago. While in Morocco, he stayed with family in an urban area and attended a large crowded gathering. During a day trip outside the city, he visited a local market and a tourist site where camels were present, reporting close proximity and photo interactions, but no known bites or injuries. He's been on a bunch of flights to get back and forth, but he has no significant past medical history. On exam, he's febrile, but his lung exam is clear and his oxygen saturation is normal on room air. So before you do anything else, do you want to isolate this patient? No, we have this international travel, we've got fever and a cough, and there was a camel. My gosh, everyone is going to isolate this patient. So what are we thinking about? Okay, so we just talked about measles, travel, cough, fever, could be measles before the rash. But you also want to be thinking about Ebola, maybe MERS because of the camel exposure. One thing I did want to bring up was the flu. So remember that we may be out of flu season in the northern hemisphere, but if a patient has had travel to the southern hemisphere, you may still be thinking about flu, perhaps not in this case. And then as always, there's COVID, which doesn't necessarily have a seasonal regularity. So what do we know so far from his history? We know where he traveled. So he's been Morocco and Boston. We have some idea of what his exposures were. Yes, there was a camel involved, but he's been around large groups of people in close proximity. And we know that when his symptoms started relative to travel. So he's had about 3 days of symptoms at this point. What you don't want to miss is MERS. And the incubation period for MERS is 2 to 14 days, but the median onset is between 5 and 7 days. The key is having direct contact with infected camels. Indirect contact could also be considered if the patient reports eating undercooked camel meat or drinking unpasteurized camel milk, and then travel to an endemic area. You may want to think about tuberculosis, but the incubation for TB is weeks to years, with a median of about 5 months among recent transmissions. Risk factors include travel to an endemic area, and among those who progress to active disease, 45% will progress to active disease after exposure within a year, up to 62% within 2 years, and then overall, there's a lifetime risk of 5 to 10% in immunocompetent hosts. But again, don't forget about local respiratory viruses, your common colds, rhinovirus, coronavirus, influenza, if it's the right season, either regarding travel or locally, and they have shorter incubation periods. Risk factors include seasonality and sick contacts. It really helps to know where potential exposures to some of these higher risk pathogens are occurring. So you can see that in this map for Middle East respiratory syndrome, really Morocco is not highlighted. You can see that Saudi Arabia and the Arabian Peninsula tends to be where we would be of most concern. Although Morocco has reported some MERS cases in camels themselves, we have not seen active human transmission recently. Also want to think about where tuberculosis is endemic. And then just thinking locally, look at the upper respiratory infections. So you can actually track this through CDC to see what is circulating in your area. And as of the time of this screen capture, you can see that in gray, rhinovirus was leading the charge. Remember, for fever and a cough, if you're thinking MERS, this is a higher level of isolation. You're going to want to use an N95 respirator, gown, gloves, and eye protection. For TB, you would be using airborne precautions with an N95 respirator or a PAPR. And then for respiratory viruses, you want to be thinking droplet precautions first. Certain diseases will require the addition of contact precautions as indicated by standard precautions if there's a large amount of secretions or as per institutional policy, and the same goes for eye protection.
Okay, so who should be tested for MERS-CoV? I think Dr. Coffey went over this. So this is just the guidance from the Centers for Disease Control and Prevention. As you can see, you need clinical features plus at least one epidemiologic risk factor. In terms of the test itself, the gold standard is PCR for MERS, and I will say that this is really only done at the CDC, and so this will often be coordinated through your public health laboratories. Preferred specimen type is nasopharyngeal or oropharyngeal swabs. You can get a sputum or lower respiratory tract specimen as well, and if someone has severe disease like pneumonia, that's actually preferred. And specimens should be collected with 7 days of symptom onset. I will also say the CDC does recommend testing for other common respiratory viruses. As Dr. Coffey has mentioned, we know these are circulating. And so certainly speaking with your local laboratories about what they can offer will be important in this setting.
So not all camels equal MERS. Diagnosis revealed. This patient who had been traveling recently and flying recently, maybe no surprise, has rhinovirus or the common cold. All right, last case, and I hope you're appreciating that these kind of general symptoms or syndromes may be the ones that you'll be presented with in these cases where we have travel overlying endemic exposures. What happens at the tailgate? A 29-year-old man presents to the ED with acute onset fever, abdominal cramping, and profuse diarrhea for 36 hours. He reports nausea but no vomiting. Stools are loose and frequent, and he's unsure if he's seen blood in it. He traveled to Boston from New York City to attend the World Cup and participated in a tailgate prior to an outdoor public watch match. So you can see what these tailgates might look like, where multiple different stations sharing food amongst a lot of people. He had poultry, sausages, some shared side dishes that had been sitting out for a little bit. And several people ate the same food, but he doesn't know if any of them are ill. He denies any recent antibiotic use or hospitalization. He's not traveled internationally in the past several months, and he has no known sick contacts outside the event. He's febrile and mildly dehydrated. So do you want to isolate this patient? He has a fever and profuse diarrhea. See what we get for responses. Is this just a GI illness? I need to know more before ordering isolation precautions. Good, this is a little bit more of a spread. And I think what this calls into question is basically just your contact precautions. Is he continent at this point in time? Do you have a risk or do you have a concern for a diarrheal illness that is easily spread to others or something that can be contained? So those would be great questions to ask. What are the things that you're thinking about? Perhaps they are food poisoning comes up as a big one. It's always the egg salad or the potato salad. That might include norovirus. C. diff would be a consideration, although he said he did not have any exposure to antibiotics. But remember, even though he didn't travel, he is at a place where people are coming to him from endemic settings. So we could still think about typhoid, Shigella, Campylobacter, and then staph preformed toxin is just another word for food poisoning. So these are all great ideas. What questions do you want to ask in order to know what might be going on? You want to know, is anyone else sick? Did everyone who ate the potato salad get sick? That's going to give you a clue. What did you eat specifically? We know that he ate poultry, sausage, and some side dishes. The things that you might not want to miss in this patient would be something like hepatitis A, which we don't think about frequently in this country, although we do see sporadic outbreaks and they can be related to food and water contamination. The incubation for Hep A is the incubation period for Hep A is 28 days, but can be in a range from 15 to 50. Risk factor being unvaccinated, consuming contaminated food or water, and international travel to areas with high endemicity or contact with people who have traveled from areas of high endemicity. The reason that this is do not miss is there may be an indication for post-exposure prophylaxis for other people who were in the same setting who may be unvaccinated. Please also remember that some diarrheal diseases may be reportable to your public health department, and those are identified in red here. You might also want to think about Campylobacter, incubation 2 to 5 days. And risk factors include poultry consumption, recreational water contact, so accidentally ingesting water while swimming, and that can be in fresh water. Dining out, just because we have seen some of Campylobacter outbreaks related to restaurants. You also want to think about Shigella because it has a very low infectious dose. The risk can be increased for men who have sex with men through sexual transmission, but also travel to an endemic region. But don't forget about the more common things like norovirus, enterovirus, adenovirus. We talked about C. difficile. Again, we would want to know more about antibiotic or hospital exposure for those things.
Okay, so when should we perform diagnostic testing for diarrhea? The diagnostic approach really depends on many factors, including the patient's age, disease severity, their host status, whether it's community versus nosocomial onset, the disease duration, the geographic location, or if they've traveled, and then, of course, the time of year. I will say, though, in general, most people do not need testing for diarrheal illness, diagnostic testing. And the reason for this is that most entities are self-resolving. And I will say in the emergency department and outpatient setting, there might even be limited insurance coverage for diagnostic testing. For example, some of those larger molecular panels that we now use. And so I really think it's important to think about whether or not this patient truly needs testing, or is this just a self-resolving illness? There are, however, some times where you should perform testing. And I think, a lot of this makes sense. Patients with moderate to severe disease, if they have bloody diarrhea, they have febrile, they have dysentery, if there's concern for a nosocomial pathogen, or if the diarrhea persists. And so here's just an outline of the different types of infections that can cause diarrhea, what their presentation, indications for testing, and the diagnostic test of choice would be. So the most common viruses that we see are norovirus and rotavirus. This tends to cause an acute gastroenteritis, which is often associated with vomiting and diarrhea. The times where you would want to test would be immunocompromised patients who can develop prolonged illness from this, or for infection control or outbreak investigations. And I would defer that to the local infection control teams there. I will say most of the time this is self-limited and does not require testing. If testing is performed, PCR or antigen testing from the stool can be done. Community-acquired bacteremia is most commonly Salmonella, Shigella, and Campylobacter, as well as enterohemorrhagic E. coli. There are also some other pathogens depending on exposure history. These patients will have diarrhea that's acute onset, and they can also have systemic symptoms. And here's where you might consider testing if they have fever, bloody diarrhea, severe illness. Immunocompromised patients, because they often require treatment, they can also have prolonged periods of infection. or if they have diarrhea that persists for 7 days or more. Molecular stool pathogen panels can certainly be performed. Culture is also available. And I will say, if you are concerned about some of those less common causes of diarrhea, like Yersinia or Vibrio, please let your laboratory know because they'll need to add specific media to help improve our culture capabilities. Nosocomial bacteremia is really C. difficile. I won't go through that. I think we're all very familiar with the risk factors there. And your local hospitals or healthcare systems will have algorithms already designed for this that are often two-step processes. And then finally, when we think about parasites, the most common ones that we see are Giardia and Cryptosporidium, but there are definitely others depending on travel. Here they can have acute or subacute non-bloody diarrhea. And so for the most part, testing is really only needed if symptoms persist for 7 days or more, because that's really when you're going to be a lot more concerned about those. Travel and epidemiologic history are also going to be important there. Here there are different tests, and again, speaking with your local laboratory about what they perform is important. There are direct fluorescent immunoassays for Giardia and Cryptosporidium. There's a standard ova and parasite examination, and then a lot of the molecular stool pathogen panels also have some of these parasite targets with them as well.
Well, you did some stool testing and you got your result back. This was Campylobacter. And remember that this was in red and is reportable to public health because the concern that there may be others who were exposed to the same foods and there may be a need for an outbreak investigation and prevention.
Okay, awesome. You guys made it. Those are some excellent cases. Thank you, Dr. Coffey and Dr. Turbot. Just want to leave you with a couple thoughts. This was very rapid fire, but hopefully you'll have a framework and you won't be daunted. You will get a sense of where a good targeted history can be your friend. And I love what you were saying, Dr. Coffey, about like the reverse travel history for our travelers. That's really critical. Think the mantra, identify, isolate, inform. You know, you can isolate up front and then you can peel back, but it's always important to think of it and make that an active decision. And obviously you're communicating with your local infection control team and public authorities. Keep your eye on the goal here. And I just want to end with a scene from last World Cup. I have to admit, my family's from Argentina, so we do have some preferences in terms of this year's World Cup. And with that, we're going to leave you with some resources, and you'll have these in the recording. I actually have all of these state public health numbers programmed into my phone so that they can be on speed dial. And I want to highlight that the Mass DPH has this great website, which has a lot of really good information about preparing generally for public health during the World Cup, not just infectious diseases, but there's really great resources for you there. The other thing I was thinking, Dr. Coffey, as you were describing foodborne illness, is MDPH has an app for patients or individuals out there, not so much patients, to report their meals if they're concerned about a diarrheal or other GI illness after eating. And there's a website, if you look up Report My Meal, where individuals out there in the public can report their meals. It's not for us as clinicians, but it is out there for people in the community. So with that, I will stop and take a look and see if there's any questions. Let me bring the screen over here. Take a look at the Q&A. And if anybody wants to speak on mic, just raise your hand and then Sam will pull you into view. So we'll give everyone a couple minutes or a couple seconds to come up with their ideas. Okay, well, hearing no questions, want to thank everyone for attending. We had a great audience here today. If any questions come up, you will see the recording on the RDHRS webinar, and make sure you get your credit for attending with the code that was previously provided. And thanks so much for attending today. Take care.